Hi everyone, welcome to week 8. So I'll be taking you through a series of videos and we're starting off with general examination and vital signs. So this is clip 8.1 and it's an introduction on general examination. So let's recall what you've gone through with Priscilla the last couple of weeks. You probably talked about a medical interview, initiating the session, and gathering framework, and the Calgary-Cambridge Guide to Medical Interviews is probably what she took you through. So for my segment, we'll be going through the physical examination part, and this is just a part of your journey because there's many more things that you'll be doing as clinicians following this, including the explanation and planning, and closing the session with your patients or your clients. And here are the objectives that we will cover for week 8. We will then try to describe factors that affect appearance, behavior, and mobility of a person. In videos 8.2 and 8.3, we will be explaining the implication of physical parameters such as height, weight, and vital signs, the temperature, blood pressure, pulse, and respiratory rate. And in the live class next week, we will then demonstrate the ability to take the above listed vital signs, of course, notably the blood pressure measurement. And we will also be performing blood pressure monitoring using a stethoscope and a manual sphygmomanometer. Isn't that exciting? I'm looking forward to having you in class. Let's start off with the setting. The privacy is extremely important. We need to be pulling curtains shut if we are examining patients, particularly if we're going to remove their clothing. We need to talk quietly, be careful of the deaf or the elderly patients because they may have difficulty hearing you or trying to communicate with you. The room should be warm and well lit. Natural light is preferred for you to observe any discoloration of the skin or any other features of your client. Now, it should be warm, otherwise your poor patients will be cold. The poor people will be shivering. The height of the couch and the bed and the backrest should be also adjustable. You should assist patient to get onto it easily. I'm sure you've seen many times how patients struggle to get on and off the hospital bed, and so we must take the trouble to lower it to their levels just so that we avoid a possible fall. We need to seek permission and sensitively expose areas of bodies to be examined. Remember to ask whether it's okay to examine them by telling them the procedures involved. And this will be covered very much in the physical examination module that you will have coming forward. Cover the rest of the patient with a blanket that you're not examining or sheets to make sure that they don't become cold. Now, if it's going to be a female patient, give the opportunity to replace her bra after a chest examination if you were to carry it out. Now, tactfully ask relatives to leave the room before physical examination because you don't know whether they're sensitive to even their family members seeing them in the relatively undressed state. Allow the relative to stay if the patient is apprehensive or if a translation is required. Offer a chaperone for immediate examination to prevent misunderstanding and to provide support and encouragement for a patient. Now, remember, before you start your physical examination, put all the equipment before you, otherwise you'll be struggling and the poor person will be lying on the bed wondering what's going on, and the impression it will be that you are very poorly organized. So the general survey is first to keep an open mind when you talk to the patient or when you observe them walking into the room. And first impressions are extremely important. Remember, while first impressions are important, that you should not be unduly swayed by early clues in the history. I have many a times when I train younger pharmacists, have been stuck with them in situations where they already have a predisposed idea of what it could be. And sometimes that actually colors the impression of what the true diagnosis is. Now, don't overvalue recent or memorable cases. You know how people say when people have experienced, especially a very traumatic one emotionally, they tend to fall back on that impression again. Sometimes when you have a bleed, you kind of think of every bruise as a bleed as well. And this is critically important to keep your mind open because you want to be able to go through all the possibilities in your mind. Remember, the differential diagnosis is critically important, especially when you go through your OSCEs. Don't try to lean too heavily towards a diagnosis which seems to match a pattern. Again, be reminded to maintain an open mind as you interview your patient. So the three elements of a general impression would include the mobility, the gait and posture, and we'll go through more details later. The behavior, how strong a handshake is, or the general demeanor of a person, whether they're collected or they're anxious. The appearance, like their facial expressions, do they look concerned? Do they look anxious? What their clothing is like, because it gives you a sense of potentially their financial capabilities as well. Not that we're judging, but also it helps us to make a decision collectively when we're talking to a patient or when we're offering therapies. Of course, don't predispose yourself to any sort of prejudices. Now, the complexion of a person is also important, and we'll go through some details later. Also, the odors, where I remember very clearly when I see some patients in clinic, when we try to talk about smoking cessation, they claim that they stopped smoking, but actually you can still smell the cigarette when you talk with them and in their clothing. So you know that they haven't really completely quit their smoking as well. So what is it that we're referring to when we talk about mobility, right? When the person walks towards you, particularly when they open that clinic door and they're heading towards you, observe the person as they walk towards you, and you can tell what their gait is like, whether there's controlled muscular strength, or sometimes when they're in pain, they tend to favor the leg that is in pain. And this gait may be an important neurological musculoskeletal disorder or provide clues to you on emotions and overall function. Like when someone is really upbeat, they will be coming into the room with a spring in their step. But if they're going to be depressed, you can see that they will be dragging their feet literally, walking slowly, and a very down effect towards how they walk towards you. Whenever there are disorders of gait, they can occur mainly because of pain, any sort of fixed or immobile joints, muscle weakness, or abnormal limb control. Potentially, if you think about a Parkinson's patient, for example, that halting gait, you can easily grasp what I'm trying to tell you. Now, if the person is in bed or wheelchair, look at the posture of the person. Sometimes they could be contractured, sometimes they could be flat, and all these are signs and symptoms and gives you clues about the previous medical history of a person as well. So this figure gives you some abnormalities of gaits, and they describe to you the various gait. I think you'll probably think about the spastic hemiparesis as a person with a history of stroke before, or some sort of a the neuron lesion, like maybe an accident that's happened. A steppage gait, this is the foot drop where you have some sort of neuropathies, maybe lower motor neuron disease. Any sort of sensory or cerebellar ataxia. It can be caused by polyneuropathies or any sort of infections from before, like syphilis. And the Parkinsonian gait, I think, is quite unmistakable. They'll be like walking with their arms this way, and they'll be shuffling, and sometimes they have difficulty stopping when you ask them to stop. What should your professional behavior be? You should always greet them in a friendly but professional manner. Hold their hands very tightly as you shake. But now with COVID, I think you can't shake hands anymore. You can fist bump. Note if the right hand works. And sometimes, this first greetings is actually useful. If someone has hemiparesis before, they may not be able to shake your hand with the right hand. And maybe they can only use their left hand well. Avoid too firm a grip, especially if the person has arthritis. You may be conferring pain to the person as you try to shake their hands. This is a table on potential information on a handshake, and you can read that in your own time. Also notice the general demeanor, whether the person looks well, whether they look anxious, recognize anxiety, fear, anger, or grief, and explore the reasons for this. This actually is very good for you to open a conversation with your patient, to also establish some rapport with them. And if someone is inappropriately cheerful, that's also a sign that something is wrong. So it also gives you a window, for the want of a better word, towards what they're really thinking or what they're really having as a problem at home as well. Okay, so where the facial expression is concerned, these are lists of various expressions that you could see with various disease states. So even facial expression can give you clues about what conditions a person might have. The clothing also can give you some ideas about a person's personality, the state of mind, and social circumstances. I think you would also have seen and heard or read about how depression is associated with poor dressing and then also crumpled clothing. Young and dirty clothes could suggest an alcoholic or drug addiction. Someone who is elderly with unkempt facial, unkempt looking, with fecal and urinary soiling, may not be able to look after themselves, and so they could be living alone, or they could be immobile, or dementia, or maybe some other form of mental illness. Anorectic patients tend to wear very baggy clothing, so that could be a suspicion when you see someone with very baggy clothing. And if someone has tattoos, you might want to consider blood-borne viral infections, for example, hepatitis as well. All right, so what about complexion that we need to be noting? So complexion can be determined or dependent on oxyhemoglobinemia, when there's reduced hemoglobin or excessive melanin as well as keratin can also cause yellowish complexions. So these are pictures of people, for example, the gentleman over there, which is a phenothiazine-induced pigmentation, which is grayish, slate gray type of complexion. And the lady in the right-hand side is like presenting to you the brownish tinge of a CKD type patient. I'm sure you've seen quite a few dialysis patients that look like that, and you know what I mean. There are also anemia type patients where you pull down the conjunctiva. They look a bit pale. The mucous membranes of the conjunctiva looks pale. They've also got pale lips as well as tongue. And also the nail beds tend to be palish. People with iron deficiency anemia can present with angular stomatitis, which is what you see in the picture in the middle over there, koilonychia, which is spoon-shaped nails, and blue sclerai. So it's important to maybe think about asking bowel habits as well as menstrual periods. There could be pallor from vasoconstriction, like when people are fearful or they're about to faint. I do recall having a patient, something like that before, who was very close to fainting. And I recall that her blood pressure was quite incompatible with life. It was, I think, 80/40, and it was a case where she had excessive peritoneal dialysis exchange, and I think that it was just too much fluid that was pulled out from her dialysis overnight, and therefore her blood pressures were extremely low, and she looked like she was close to fainting, and so I was a bit panicked also in clinic. Some pink complexion type patients could represent vasodilatation, and this can even occur in anemia, so it gets a bit confusing. So perimenopausal women, for example, could experience transient flushing, so you can actually see them all flushed up, which may or may not be accompanied with sweating. Facial plethora is a situation where you get elevated hemoglobin as well as hematocrit, and that's the flushing in the face. I don't think that's very commonly seen. I think locally there are a bit more pale people than there are flush people. Odor, what's there to do with appearance? What are the special odors that come from different people? Well, everyone has their own natural smells. Some people have body odor, and that could be a sign of excessive sweating or poor personal hygiene. Sometimes dirty or soiled clothing. I'm sure you've had experiences before with some patients where they come to clinic with stale urine smells, and those are potentially people with BPHs and have difficulty controlling their urinary habits. Excessive body odor can occur in the extreme old age or infirmity, people who are very old and somehow they don't quite get around to maintain their personal hygiene, people with major mental illness because they can't seem to manage their mental faculties as well as their usual urges to go to the toilet, people with alcoholic or drug misuse, somehow their executive function is also affected, and physical disability preventing normal hygiene, and some of them severe learning difficulties. And this is a very famous one, the tobacco smell. I'm sure a lot of you also have smelt it when you see patients or even when you dispense to patients. And this is a sure way for me to tell when patients are bluffing that they've actually quit smoking, because you do really have to have been exposed to quite a lot of cigarette smoke in order to smell like cigarettes. And of course, alcoholism is a very classic smell. I'm sure all of us have smelt what it is like to be next to a drunkard who reeks of alcohol. And a smell in the morning could suggest some alcohol problem if the patient presents to you in the morning. The other thing is halitosis. Now, halitosis is, I think, fairly common, particularly for people in our line, because you spend all your time talking and sometimes you don't have time to drink water. It's often caused by decomposing food that's wedged between the teeth, and gingivitis, stomatitis, sometimes even rhinitis, and tumors of the nasal passages can lead to halitosis. And this is a list of other causes which are quite classic of breath changes or smells in the breath. And I think that the particularly very interesting one would be the uremic feta or fishy or ammonious smell for those who have got uremia. And I think this is potentially something that you might look out for, especially if you take care of CKD type patients who have maybe undergone or are undergoing dialysis. Okay, ladies and gentlemen, let's go on to clip 8.2 on height and weight next. See you later.